Hello everyone, and welcome to our 7th week of our course on drugs and behavior. This week we'll be talking about depressants and inhalants. Uh, so depressants are in many ways the opposite of what we studied last week, which were stimulants like cocaine and amphetamines. Depressants are going to have sort of the opposite effect on the nervous system and behavior, and it turns out that they have a larger number of sort of legitimate uses. They're still at risk for abuse, of course, but we'll talk about the therapeutic uses a little bit more in this unit because there are just more of them. Okay, so by way of overview, we're looking at depressants. So first we'll define what they are. Then we'll go over the history of depressants. How are they developed? What are they used for? What effects do they have, both on neurons and on behavior? And of course, the effects on behavior are why they're used both illicitly and legitimately. We're also going to talk about inhalants. And inhalants are sort of a different group of drugs. They're a little unusual. We'll actually talk about them next session. But they tend to have depressant effects, so they're included in this unit here. So in particular, this session, we'll define what a depressant is. We'll talk about how depressants affect neurons. And depressants have a fairly common effect on neurons. There are a couple of exceptions. But really they all more or less do the same thing. And where they differ is the subtype of receptor that they affect and how long it takes them to come into effect and how long the effects last. And we'll talk about the history of depressants, how are they developed. And finally, we'll understand the final applications of depressants. They're used for different things, as I mentioned, sort of a wider variety of uses than stimulants are. Stimulants, as we talked about last week, are mainly to keep you awake and vigilant. But depressants have a number of other uses. So first, a little housekeeping. The midterm exam is coming up, so not this week, but next week. You will have next week to complete the midterm exam, which will be online, administered through Blackboard. So it's due by 11:59 p.m. On Friday the 16th. So take it at your own, take it at a time of your choosing. It is a closed book, closed note exam. You will need the Respondus Lockdown browser. So I've gotten a couple of questions about this. You do need to install the browser to take the exam. You don't need to have a camera on your computer. I do not monitor the video from people taking the exam, so you don't have to worry about that. Pretty much any computer will do, but you do need that browser to take the exam. And you can find that browser through Blackboard. I also posted a link to it in the original course announcements, so you can find a link to the browser there. It is a timed exam, so that's one of the ways I have to enforce everyone having the same amount of time for the exam. So it is timed, so as you take the exam, be mindful of how much time you've taken so you don't run out of time and have to leave some questions blank. So what's the format of the exam? So it'll largely be multiple choice. So if you've taken the practice quizzes, same sort of format. There will also be some fill in the blank questions, which will be a little bit different. There you'll have a variety of options. You'll sort of have more options for what to fill in and more blanks to fill in than just the one. So it's a little different from multiple choice. I'm sure you've all had fill in the blank questions before. And there'll be a couple of short answer questions. And these are questions where you use your own words to answer the question in a couple of sentences. So not an essay, you just turned in a paper, so I'm not going to make you write a long essay in response to questions, but just to test how you can describe events in your own words, especially controversial issues. Not that controversial issues have a definite answer, but to make sure that you're aware of what some of the issues are, not that you have to demonstrate one side or the other being right. But short answer questions, so a couple of sentences in your own words, that'll be that. So what's the content? The content is everything that we started with up through this week. So next week is when the exam is. You won't be tested on that content because it'll have just come online. You won't have a chance to absorb it yet. But everything from the introduction through history, how drugs affect the brain, the history of regulations, for example, drugs in society, and stimulants and depressants and inhalants. So all of that will be on the midterm. So it also covers content from both the textbook and lecture, and we'll get to that in a second. So how do you prepare? So anything from the textbook and lectures is fair game. I would concentrate more on the lecture material, though. So that's the stuff that I've deemed more important. So both your book talks about it, and I've talked about it in lecture. Obviously, the lectures are posted, so feel free to go back and look at them. The slides are available as well as you prepare. In terms of what you need to know and don't, you don't need to know both the chemical name and the brand name. Either one will do. I will always give you both of those. So you don't need to know that zolpidem is Ambien, for example. We'll talk about that today. You don't need to know that mapping. I'll always give you both names, so knowing either one will be fine. You also don't need to know exact dates. So you don't need to know the range of dates during which the Opium War occurred. There were actually two. But it's good to know that the Opium War occurred in the 1800s before there were regulations on things like opiates. So knowing the events and the order they occur in helps put things in context. Everything sort of fits together. Usually new drugs are synthesized, and then laws and regulations in society respond to the presence of the new drug. Of course, many drugs are natural products and have been around for centuries or millennia. But it helps not to know the exact date. You don't need to know when methamphetamine was first produced, but it was in the 20th century. And so it helps to understand sort of the sequence of drug development, regulations, and society's response. The practice quizzes are available, and they are good practice, so it gives you a feel for the sort of questions I ask. And also, it's just a good way to test your knowledge on each unit. I know many of you have been using them, but not everyone, so feel free to try those to figure out where your weak spots may be in terms of the content we've covered so far. So in terms of what you should focus on in particular, as I mentioned, everything is fair game, but I would pay special attention to how action potentials work and how synaptic transmission works. Not that those will be overrepresented in terms of the number of questions, but those are areas where people tend to have a little more trouble. And so if you don't understand those as well, you may want to focus on those more, because I will ask questions about how these things work, and in particular, how drugs affect these processes. So know how every drug that we've talked about affects the brain and behavior, especially the drugs that we've already devoted entire units to, things like stimulants and depressants. We haven't talked about alcohol, caffeine, marijuana yet, except in passing. So understand how drugs can affect the brain and affect behavior. So know the difference between a direct and indirect drug in terms of being an antagonist or an agonist. Know those four terms. What do they mean? What does that mean for synaptic transmission? So understand both the short and the long-term effects of drugs. So oftentimes I will split the short-term effects of a drug on both brain and behavior from the long-term effects. So long-term effects are usually things like dependence, tolerance. Short-term effects are things like euphoria, decreased pain perception. So know which things are which. Also understand the regulations. At first there weren't any, but the regulations for drugs that have appeared throughout history, and how those things are responses to the development of drugs and to the development of certain patterns of use. Obviously, opium has been around for millennia, but there were certain patterns of use that developed in the 1800s, and obviously there were events in history and regulations that were really responding to that, the different pattern of usage, not just the presence of the drug, because the drug had been around for millennia. But trying to understand that in a historical context, how these laws and attitudes have changed over time and in response to the appearance of drugs and new patterns of drug use. Okay, so on to our unit on depressants. First, what is a depressant? So a depressant is sort of the opposite of a stimulant. It's a drug your book says slows activity in the nervous system. I think it's more accurate to say that it decreases activity in the nervous system. Action potentials still travel down axons just as fast. They're just less likely because of depressants, and for reasons that we'll see in a minute or two. So depressants don't make you depressed in the psychological sense. So the depressant, the use of the term depressant here, just means it decreases activity in the nervous system. The opposite of a depressant is a stimulant. It is not an antidepressant, which is a class of drugs we'll actually talk about next week. So bear that in mind. A depressant describes what it does to the nervous system, not what it does on a psychological level. So, as with all drugs, there are short-term effects and there are long-term effects. Some of the common short-term effects and what these drugs are often used for is decreased anxiety. So whether this is a chronic condition, as in an anxiety disorder for the person, or just a short-term stressor, depressants can relieve that anxiety. They also decrease movement, and that'll be important for disorders like epilepsy that we'll talk about here in a bit. And then finally, they can induce sleep. And a lot of these effects depend on the dosage. There are depressants that will decrease anxiety in smaller doses and put you to sleep in larger ones. So what are some examples? Well, alcohol is certainly a depressant. There's no question about that. We remember from a few lectures ago, alcohol is in the class of drugs that we call depressants. It's not covered in this section because alcohol is such a big topic that we actually have a whole week devoted to alcohol a couple of weeks from now. So alcohol is a depressant, but we're not going to cover it this week because it's a very big topic, both socially, chemically, and biologically. So alcohol we will reserve for another time. Cannabis is sometimes classified as a depressant, oftentimes not. So cannabis in smaller doses can have depressant-like effects, but it has multiple effects at once, and some of those are not decreasing activity in the nervous system. In sufficient quantities, cannabis can actually be a hallucinogen. And so we don't classify cannabis typically as a depressant, even though it has certain depressant-like effects. Barbiturates are a very common, or at least they were a very common class of depressant. As we'll see, they become less common with the development of less risky drugs. The benzodiazepines are very popular. They're also depressants, and they're in very common use even today. There are lots of them. We'll talk about some of them. And so these are the prime examples of depressants, with, again, cannabis being sort of a questionable member of that category. And we have a whole week devoted to marijuana later on as well. So what do depressants do? So we mentioned some of the effects that depressants have. First, how do they have their effects? So the way that works, depressants work, is through what are called GABA receptors. If we recall, GABA is one of the main neurotransmitters in the brain, and it's the main inhibitory neurotransmitter. So here on the right, we see a diagram of the relationship between action potential and a particular kind of neurotransmitter. So on the top, we have a typical response for something like glutamate, which is an excitatory neurotransmitter. It increases the likelihood of an action potential in the postsynaptic neuron. So if we're recording from the presynaptic neuron, we see an action potential come down to the end of the axon terminal, and then in the postsynaptic neuron, we see a depolarization. That is a change in the membrane potential that gets closer to the threshold under which the neuron would fire. So glutamate increases the likelihood. You get enough glutamate transmission, and that postsynaptic neuron will fire. But GABA is the opposite. It's our inhibitory neurotransmitter. And so when GABA is released into a synapse, it actually decreases the likelihood of an action potential happening by hyperpolarizing the neuron. And that's what we see in the lower panel in this diagram on the right. So we see an IPSP, which is an inhibitory postsynaptic potential. And that's how depressants decrease the amount of activity in the nervous system, because overall they make action potential is less likely because of GABA. So there are actually two kinds of receptors, and different depressants affect each one to a different degree. But there are GABA A receptors and GABA B receptors. GABA A receptors are ionotropic, which means they let ions in directly. They have very fast courses of action. So GABA A receptors are ionotropic. GABA B receptors are metabotropic. And hopefully you remember this from our unit on drugs in the brain. The metabotropic receptors start often complex chemical cascades inside the postsynaptic neuron. So ionotropic receptors are simple and they're very fast. They just let in ions. Metabotropic receptors are slower, but they can have longer-term effects. And so this is important when we talk about different time courses for different drugs. It's often a function of which kind of receptor the depressant binds to. So GABA receptors are bound to directly by most depressants. So they are direct GABA agonists. Remember, an agonist is something that enhances or mimics the effects of a neurotransmitter. So in this case, these depressants bind to GABA receptors and increase the effectiveness of the neurotransmitter GABA. So in low dosages, you get relaxation, reduced motion. So again, sort of a small decrease in activity. Of course, if you bump up the dosage, you're going to get a bigger decrease in the activity in the brain. And so eventually that'll put you to sleep in a high enough dose. And of course, in a really high dose, you'll interfere with your autonomic processes, things like respiration. So with enough of a depressant, you'll stop breathing. And that is one of the dangers of overdosing on depressants, is death through such a marked decrease in activity that your autonomic functions stop altogether. And of course, especially with higher doses, but obviously not lethal doses, through chronic use you can develop dependence, which is a problem with many drugs that we'll talk about in this course. And as we've already seen, what usually happens in dependence is whatever symptoms or whatever behaviors are alleviated by the drug, once the person becomes dependent, if they stop that drug use, the withdrawal symptoms are often the return of those behaviors. So if you take painkillers chronically, as soon as you stop taking them, if you're dependent on them, you'll become super sensitive to pain. Similarly, if you get used to taking depressants, at first they relieve anxiety and help you go to sleep, but if you stop taking them, if you've been taking them for a while, now you'll get a sudden increase in anxiety or a difficulty sleeping because the drugs are no longer there to assist in that function, and your body's become used to them. Okay, so some history on depressants. So we're going to talk about synthetic depressants first, and that will be the main focus of this week. As I mentioned, marijuana is arguably a depressant. Alcohol is certainly a depressant. But those are big topics we'll save for later. They're also naturally occurring, and that's one of the distinctions we're going to make here, is that almost all depressants that we're going to be talking about this week are synthetic. So they haven't been around that long. They've been around usually since the 1800s. There's one or two that were probably developed in the 1700s, particularly in the inhalant class. But most of these are synthetic. So when we talk about early history, we're really talking about late 1800s. So chloral hydrate was one of the first to be developed in the mid-1800s. If you've ever heard the phrase slipping someone a Mickey, that's a reference to a man named Mickey Finn, who was a Chicago bartender and would slip chloral hydrate into drinks of certain patrons, particularly wealthy patrons of the bar. The person would fall asleep, and then people could rob them at will. But chloral hydrate is a depressant, and it can be used to, in small doses, alleviate anxiety, in larger doses to put someone to sleep. But again, the most famous use of chloral hydrate is its illegitimate use in putting people to sleep. There's also paraldehyde, which is actually an effective depressant and not a very dangerous one. It actually has a wide, what's called therapeutic range, which we talked about a couple weeks ago, and what that means, of course, is that It doesn't take that much of the drug to be effective, and it takes a lot of the drug to be lethal, to be dangerous. And so it's actually a fairly useful substance. The trouble is it smells terrible, and so people don't like to use it. Also, it's been superseded by newer drugs that don't smell terrible, so it's not really used that much anymore. Bromides were also used particularly to help with sleep. They have some side effects. They're irritants, so they can irritate particularly the lining of the stomach. They also have higher potential for overdose and abuse, so they're not really prescribed that much anymore either, and very few drugs even contain any bromides at all. The first big class of depressants that were widely used are the barbiturates. So some of these are famous. Barbitol, for example, is one of the first ones. Secobarbital, which is a small modification of barbitol. Here on the right, we see, again, sort of an old bottle for the medicine. This is barbitol under the brand name Veronal. And we'll see a lot of that in this unit. We have both the chemical name and the brand name. And some of the brand names you will likely recognize. So there are actually a large number of these barbiturates. One of them is sodium pentothal, which many of you have probably heard of. It's also known as thiopentyl sodium. The American and the British chemical societies sometimes come up with different names for chemicals. That's just something we have to live with. Sodium pentothal is famous primarily as a truth serum. So during interrogations, sodium pentothal has historically been administered trying to get someone to convey sensitive information. It does make someone more relaxed, it does make them more talkative. Whether it makes them more truthful or not is very controversial. Also, sodium pentothal is used in the lethal injection mixture in executions. So it is injected as part of a combination of 3 drugs. It's the first one. It induces unconsciousness, and later ones stop breathing and stop the heart. So sodium pentothal is one of the famous barbiturates. But there are actually over 2,500 different compounds that qualify as barbiturates. So there's a lot of these. Obviously, we're not going to go over all of them. I've mentioned a couple here, some of the most famous ones. But all of these are small chemical modifications of the same basic compound. One thing barbiturates vary a lot on is the duration of action. That is how long the effects last. And the duration of action is usually proportional to the onset of the drug's effect. So something that happens very quickly usually wears off pretty quickly as well. Something that takes an hour to kick in usually lasts for many hours before it wears off. And so barbiturates were developed and used because they have a wide range of these durations. You can have very short-term medications that are designed mainly to induce sleep. Once you're asleep, you don't need it to continue working. Whereas if it's an anti-anxiety medication, you're awake all day. If you're anxious all day, you need a longer duration of action. So barbiturates are a class of drugs that were really developed and customized based on the symptom they were supposed to address. Unfortunately, with barbiturates, there's a fairly high risk of overdose, especially if they're combined with other depressants, especially alcohol. And alcohol is because it's such a commonly used substance, a lot of drugs, if they're dangerous when combined with something, it's because they're dangerous when combined with alcohol because it's such a common substance to use. But even by themselves, barbiturates have a high risk of overdose, as well as a high risk of developing dependence. And that's one of the reasons that barbiturates were largely superseded by later drugs. They were effective, but they were also somewhat dangerous. And so drug developers worked to create substances that weren't quite as dangerous. And they succeeded. So after barbiturates, we get sedatives and depressants like meprobamate, also known as Milltown, the brand name. And this one was effective, but still had those chronic side effects. I'm not going to talk about it as much. A more famous one is methaqualone, also known as Quaaludes. And so these were popular up to around the 70s, when regulations were increased, because they were chronically abused. They were actually one of the first sort of party drugs that were depressants. And so they really became heavily used in the 60s and 70s, but they were originally a prescription medication for inducing sleep. And then finally, we have the benzodiazepines, which are the most commonly used depressant other than alcohol today. Widely prescribed, widely used, to a certain degree, widely abused as well. The first one was chlordiazepoxide, which is marketed under the name Librium. Uh, and it's not as used quite as much anymore. One of the most common ones is, of course, diazepam, which is famously branded as Valium. So this is used as a anti-anxiety drug and a sleep aid. It also has a fairly long duration, considering it's a sleeping pill. Its effects can actually last for several hours afterwards. You also have flunitrazepam, which is branded as Rohypnol, which you may have heard of. Its street name is Rupees, which you almost certainly heard of, because it's often used illicitly as a date rape drug. So a substance that's used to sedate the person who takes it. They often don't know they're taking the drug, and so it's used to make them compliant uh, and unable to resist the person who has drugged them. So that's a fairly famous one. You also have some like lorazepam, which is marketed as Ativan, and of course alprazolam, which is branded as Xanax. That's a very widely used anti-anxiety medication. It's also widely abused. Um, but these are all benzodiazepines, and benzodiazepines are a chemical designation. We don't need to go into the chemistry of it, but like barbiturates, there are a large number of these compounds, and they're designed and modified to try and minimize side effects, minimize the risk of overdose and dependence, but they're also customized based on how quickly their effects take place and how long those effects last. So now that's the history. Those are sort of the different types of drugs chemically uh, that we've developed. But in terms of what they're used for, there are a number of uses for depressants. One is what are called anxiolytics. And as you can probably see from the name, these are used to treat anxiety, and in particular, anxiety disorders. So here are some popular ones. We just mentioned most of these. Um, but these are all drugs, along with their half-life, and this is why I bring this up now, is that you can see that anxiolytics tend to have a longer half-life than the hypnotics, which we'll talk about next slide, and are designed to induce sleep. So anxiolytics, you need to last for a while. Something that reduces anxiety for an hour or two doesn't do you much good, because then your anxiety comes right back. Of course, it's not helpful for all types of anxieties, in particular things like phobias. It's not, if you have arachnophobia, if you're afraid of spiders, taking these drugs doesn't generally help you, because you have a specific object or event that's related to your phobia. There you usually need to turn to behavioral therapy. But for general anxiety disorders, these things can be very effective. One of the questions, of course, is how do we diagnose anxiety disorders? And um, that's a whole area of psychology that's not really in the scope of this course. But that's one of the issues, is if someone should be allowed to take a depressant, particularly an anxiolytic, because of short-term stressors, or are people with anxiety disorders, diagnosable anxiety disorders, the only legitimate users of these drugs? And that's an open question. It actually relates to our discussion this week. But that is one of the difficulties, is how many criteria a person has to qualify for in order to get a prescription for one of these anxiolytics. Second, we have the hypnotics, which do not hypnotize you. They're drugs that induce sleep. So they're typically used to treat insomnia, which of course, as we know, is the inability or the difficulty in falling asleep. And this is a very chronic problem, a very common problem. Many people have it chronically, but almost everyone suffers from it at some point in their life. So there are benzodiazepines, as we just talked about in the last slide, that induce sleep, things like Valium. But there are also non-benzodiazepine hypnotics. And these are things like Zolpidem, which is marketed as Ambien, and azobiclone, which is marketed as Lunesta. So you can see commercials on TV for these substances. And they help you go to sleep, but they're not technically benzodiazepines. They're also at lower risk for abuse and overdose and dependence. Benzodiazepines have a moderate risk of these things. These things, Ambien, Lunesta, are much more rare in terms of the cases of abuse and dependence. Finally, there's Ramelteon, which is marketed as Rosarum, and this is actually a different class of drug altogether. It's still a depressant. It helps you go to sleep, but doesn't act through the GABA system of neurons. It actually works through a neurotransmitter called melatonin, which you may have heard of. So Rosarum is a melatonin mimic. And the way it works is melatonin is a neurotransmitter that's thought to regulate sleep and wake cycles. So Rosarum mimics melatonin, and it's most commonly used for people that are either because of their job or because they're traveling, that the day-night cycle doesn't match up with their endogenous sleep-wake cycle, and so it sort of resets your body clock. The benzodiazepines and other depressants will work sort of no matter what time of day it is. We're still evaluating what melatonin does in particular, but it seems like these are drugs that are most commonly used to sort of reset the sleep-wake cycle. Finally, there are anticonvulsants. And so these are drugs that are used to reduce the incidence and reduce the severity of seizures. So the most common disorder these are used for is epilepsy. So here on the left we see what's called an EEG, an electroencephalogram, a graph of electrical activity in the brain of someone who's suffering an epileptic seizure. So what characterizes these seizures in the brain is a large amount of spontaneous, synchronous activity. So normally your brain is firing all the time, but here we have a really large increase in the amount of activity and also the degree of synchronization in the brain. And usually these seizures start at a particular locus in the brain. It varies from person to person, but for a given person that's epileptic, they usually start in a characteristic spot. And then these waves of activity spread from there and then pretty quickly cover the entire brain. And so one way to get at this in severe cases is surgery, just to remove that location. But if it's not as severe, then you can use depressants to lower the overall level of activity in the brain and thereby decrease the risk of a seizure. And many of these drugs are actually quite effective. More recently, it's been discovered that many of these anticonvulsant drugs can be useful as mood stabilizers, which is not an intuitive effect that these drugs would have. And it's still not clear why they have these effects. But for disorders like bipolar disorder and borderline personality disorder, where the person's mood is disrupted, it's been found that anticonvulsants can alleviate some of these symptoms. So we're always figuring out new uses for these drugs because, as we've already seen, the brain is a very complex machine. And very few drugs have one effect and one effect only. So we're always discovering more and more effects of drugs, and sometimes they're beneficial and sometimes they're not. More often the latter, but in this case, we found a new use for an existing class of drugs. Okay, so that will do it for today. Next time, we're going to look at some other depressants. So in particular, we'll look at gamma hydroxybutyric acid, also known as GHB, We'll look at why antidepressants have an effect on memory. And also we'll look at inhalants, which I mentioned at the beginning are sort of an unusual class of drugs, and we'll get to why that is next time. So in the meantime, prepare for the midterm exam, and I will see you in our next session.